Thank you everybody for joining. And like I said, sorry for the late start. It's a pleasure to have all of you join us today. For those of you celebrating Eid today, Eid Mubarak to you. And we wish you peace, happiness, and joy in this season of Eid. I also know that International Women's Day was like almost 2 weeks ago. But I just want to wish all women here a happy International Women's Day. We are celebrating the resilience of women, the strength of women, and the courage of women, especially women who experience pregnancy complications like preeclampsia. You are the real warriors, and we are so proud of you. We also want to celebrate women who continue to fight to advance the cause of preeclampsia and also to ensure that women get better care and quality care. Women that are doing research into preeclampsia, we thank you so much for your service, and we just hope that things will get better with time. So thank you for joining us today, like I said, and we look forward to having a great session with you. Before we begin, I'd like to run us through the Zoom practicalities. Please ensure that your microphone is muted. If you want to ask a question, please type in the chat, and I'll invite you to ask questions at the end of each speaker's presentation, or maybe at the end. We are recording this to put on our social media pages. And so if you don't want your video to be seen, you can just keep it off whilst we do the recording. And if you don't want your name to be seen, also just don't type your name there so that you have that privacy. All right, this is the program outline. We'll have a little bit of a meet and greet in the chat. So I just typed in the chat, please put in the chat your name, your profession, and where you're joining us from. Would like to know you better. It's always nice to hear from our audience. And so we want you to type your responses in the chat, and I'll be reading from the chat box for a few minutes. So where are you joining us from? It's interesting to me sometimes when I see people joining from Tamale, from Ashanti region, and all of those things. So please type in the chat your name, what you do, and where you're joining us from, and just a short phrase about what you're hoping to learn or take away from today's session. Don't be shy. There are so many people, and who knows, you may meet someone you can collaborate with, or somebody you can meet up after this and learn from, or learn with to improve your practice. So I'll give you about 30 seconds. And as the responses come in, I'll be reading it. So I see a couple of familiar people, I think. We have Konama, who is a physiotherapist joining us from Accra. Pearl is a midwife, and she's joining us from Accra. Magdalene is also a midwife. She's joining us from Kaswa. And Simon is a medical officer joining us from Adafo. I hope I said that right. Getty is joining us from Takwa. She's a midwife. Mr. Divine is a telecom engineer. He's joining us from Accra. Eduji is a doctor joining us from Adenta. So thank you all for joining us today. Keep typing in the chat your name, what you do, and where you're joining us from. Emmanuel says he's with us in APEC. Emmanuel, nice to see you. And he's joining us today from Dodowa. That's nice. So please keep your comments coming in the chat. And just type a very short phrase. What do you hope to take away from today's session? So just type in the chat. We also have Marlos, who is a Dutch medical doctor. He's working in Zambia, and he's joining us. So we have people joining us from Ghana, and we also have an international audience. So that's really good. Thank you all for making time to join us. Theodora, thank you for joining us today. So as I mentioned, please tell me what you're hoping to take away from today's session. Now I know a bit of your names, but nobody's typing what they want to hear from today's session in the chat. So if you can please put that in the chat, that would be really good. Esther is a senior nursing officer from Tichiman. Esther, thank you for joining. Bliss is a midwife. So we have lots of midwives, lots of nurses, lots of medical doctors, and we also have some women and some men who obviously are not medical professionals but have taken time to join us. And it's a holiday, so thank you for spending your holiday here with us today. All right. I'll be monitoring the chat from time to time, so feel free to write your comments, your questions in the chat, and I'll make sure to address it to the expert panel that we have today. Okay, moving on. This is the theme of today's Knowledge Cafe. So we are going to be looking at preconception care and preeclampsia risk reduction. So these APEC Knowledge Cafes, our main target obviously are health professionals, but we also like to target pregnant women and their families because we believe that education is both ways. It's not just for health professionals, but pregnant women and their families will also benefit. So that's the objective of having these knowledge cafes. So these are the expected outcomes. By the time we are done today, I think we'll know a thing or two about preconception care. And we'll also know about how preconception care can actually help women reduce the risk of preeclampsia. And then we can understand it better in terms of how this really occurs in the Ghanaian setting. Thank you, Benedicta. Thank you, Ernestina, for joining us. Okay. So my name is Isabella. I'm a midwife and I'm a researcher. I'm based here in Charles Darwin University in Australia. I'll be your moderator for today. It's my utmost pleasure to moderate these sessions. I look forward to it. I don't know about you, but I look forward to these APEC Knowledge Cafes because it's like mind-blowing. So much to learn, so much to uncover, and it's just really nice to meet like-minded people who want to see preeclampsia care improve. So stick and stay with me for the next 1.5 hours, and I promise we are going to have a nice learning time together. So at this juncture, it is my utmost pleasure to introduce somebody who has lived experience of preeclampsia. And I call these women our women warriors because they have gone, they have fought the battle, and they have conquered. So they are warriors in their own rights. Our speaker for today is a public health practitioner and a health systems innovator with a background in disability rehabilitation and development. She's the founder of Care Access for Resilient Africa, CARA, an initiative that explores models to support families, caregivers, and communities in delivering safe and responsive postpartum care. She's initially wanted to remain anonymous, but we fully respected that. But we are so happy that she's coming out with her full chest to share her personal story. And this really takes a lot of courage. So we applaud you for that, Joanna. And we are also really grateful about your willingness to share with us today. So the floor is yours whenever you are ready, and we can't wait to hear your story. Over to you, Joanna.
Thank you, Isabella. And I'm very delighted to be here as well. And you're right. Why hide the face? Because as a survivor, you should stand for the rest of the women out there. And I don't think there's any need to hide. I'm not hiding actually, but it's just emotional. So thank you. So I'll go ahead. I remember thinking that everything was normal until suddenly it wasn't. I mean, the third of 3 pregnancies, and this was the third. As a woman, I've passed the first one, the second one, the third one shouldn't be anything. I have to recollect my notes and try to understand what is happening. I've done it before, and I had done it with both genders, so at least I understood the journey, and it wasn't anything that I was tracking. Then what I later learned was preeclampsia. So I was going about my normal daily routines, like you introduced me, a disability aspect, public health. So obviously our work is in the field. I recall this happened around my 26th week. I had already traveled up North Ghana to conduct some trainings, two of them at least. Flew back to Accra. I decided to take a week off the office duties just to rest because for a pregnant woman, that was quite a trip. As I was at home, there was something that I realized. So I realized that my face was looking a bit different, um, unevenly swollen. And I thought, okay, pregnancy can come with so many things. So which one is this one? I wasn't having any pains then, but then strikingly, my left hand was swollen and my right wasn't. So I recall showing it to my husband as, okay, I'm looking funny at this moment. How can a normal human being start swelling on one half and the other half looks normal? We laughed over it. It's okay. Pregnancy comes with so many mysteries. So let's hope that this one isn't anything serious. Then I went to bed. 2 days after, I realized that okay, the part of my face that was swelling, when I lay down, usually when you lie down on your pillow and you wake up, and even if my face was like more like stuck, it wouldn't bounce back. Then I said, okay, this is really something. I have to really go to the hospital. A week, my antenatal was in a week, but I shifted it a week earlier. And again, I was on my way to moderate a program. Then I passed by the hospital. Mind you, I wasn't having any pains, no feeling, nothing. So I just reported myself at the hospital. I know I'm a week earlier, but then since I'm in the neighborhood, I just want to see the doctor. Nothing alarming. So when I put in my card and then I went to the room that they had to take the vitals, then I met the nurse who took my temperature as usual. If I had any pains, no. Then she took the BP. And I recall the face she gave me and the comment she made. I was like, okay, what is it? I don't know. I think she was a new nurse. And she was like, I'm not at liberty to tell you. You see the doctor. So, okay, now you're making me scared. What was my BP? Says, okay, but you have to see the doctor first. So I sat and wait for my turn to see my gynae. And when I got there, she's a friend. She sees all pleasantries that day and went straight, Joan, what are you showing me today? I said, what is the problem? Why is everybody behaving funnily today? Your BP is at 195. I said, okay. Are you sure your fig works well? Because that is crazy. Then she was smiling. You don't really seem to know what is at stake here. I said, no, you have to tell me what is happening. It was at that point that she mentioned that, okay, it means that you are hypertensive. And this figure is not anything I can let you go today. I would have to detain you. At first, I thought she was joking until she seized my laptop, my bag, and everything, and took me straight to the ward that I should wait. So I got a bed. They gave me some meds, and then I waited for about 2 hours. Then she came up to the ward to tell me everything. That was the first day I heard of preeclampsia. I mean, it was a new term to me, and she had to school me a little bit on hypertension and pregnancy. That's okay. I've heard that before, but I thought it was something that would just spike because of the stress and then probably go back. So well, sometimes it doesn't, and it comes with complications. I thought my doctor was just exaggerating until I was in the hospital for 2 weeks monitoring. So I was admitted, and then they put me on monitoring. Every 2 hours, they come and check my pressure. They had to completely change my diet. Of course, it came with medication as well. The surprising part was the injections that I had to take because Now it was a mother and child affair. So as much as they were trying to control my pressure, I had to take some serious injections for the baby as well. And it kept on going. And mind you, I have two of the kids at home. I had not planned for any caregiver, no plans at all. I only told them I was going to work, and I got stuck in the hospital for 2 weeks. So, as I was trying to save my life in the hospital, subconsciously, I had to also think of the two kids at home and who was taking care of. I think they looked at the situation and counseled that I have to find a way to block my mind from what is going on at home. Everybody is fine because the more I thought subconsciously, they cannot control the pressure, no matter the medications they gave. So I took that in faith. My husband was around, and I think he was even more scared than I was because now we had to find a caregiver to take care of the two kids at home, two strangers I didn't know, my parents not around, siblings not around. So later on, they came to help because my husband was more concerned about what will happen to me. So he was with me at the
What
hospital.
happened to me? Hospital.
So most of the time, he'll go to work, and this was a private facility, so he was allowed. And then we'll come back to check on me every evening.
No, you
Looking back,
wanted to ask.
yeah, looking back, I thought there were signs. So I settled in about a week to now reflect what may have caused the hypertension. Was it that I was overworking? Was it the traveling? What did I do wrong? I just couldn't get answers to this. I wanted to search online to read more, but something happened. I realized that now I was reacting to the screen. Any screen I watched will accelerate my pressure, and I don't know. So they had to turn on off all the TV. My phones were seized, and the only thing I was left with was a music box because they have tried the diet. They are still giving medication, but this pressure will not go down. So they turned off all screens. They realized I was reacting to the screen. So that means I couldn't read. I wanted to read more about preeclampsia to know what was going on, but I couldn't at that moment. All that they left with me was soft music to calm my nerves down. So once a while, my husband will come around, the doctors will come around, they have a chat with me. The midwives and the nurses also did well. They didn't want to scare me because I was still, I think, very young, the stage that I was at 26 weeks. But I think I settled and then accepted what was going on and tried to help myself and then help the doctors as well. It went on, and then I was discharged after the 2 weeks to go home and then manage the pressure from home and then come back for review after a week. When I go back to the hospital, I think preeclampsia doesn't know calm down. Once it sets in, it's just going. So when I reported back to the hospital, at this moment, my look has completely changed. I wasn't looking like myself. I was actually scared to look into the mirror. And I was super swollen. So I was admitted once again. And that admission didn't take me more than a week, and they had to bring the baby out. So I remember on that fateful day, the doctor came in and told me the symptoms. Do I have a headache? I didn't have a headache at that moment, but I lost my balance. So I realized that I couldn't stand. Whenever I tried to stand, I felt super heavy, then I will fall. I'll fall back to the bed. So that was when they called in the team to prepare for emergency CS. Um, then before leaving the ward, then she told me that if I get any pain on my right side or a severe headache, I should just press the bell because that will be the last of the symptoms that they are looking up to. By that time, they were still giving me the injections, the Maxol and all that they will pump in you for you to settle. So later in the evening, the team came around, and at this point, I would say the medics will not try to scare you, and then that is when they enter into their medical jargons, so that they cover up the conversations going on. So I recall my gynae tapping onto the next doctor and say, the thing has just entered her CNS. Oh, okay, CNS is a crazy one. So does that mean something is going to happen? But I picked from them that that was the severity of the condition at that point. So by evening, I was at a theater and they had to bring the baby out. So at 31 weeks, the baby came out, thankfully crying, very healthy, and then but very tiny as well. So that was the phase 2 for me. Now we had to jump into NICU. So baby got out, they had to settle me. By the time I got out, the baby was in the incubator and my pressure was still up. So for 4 days post surgery, I had not shut my eyes. I just had a lot of needles in my body trying to sustain me. Then on the 4th day, that was when I made a blink. Then I called the doctor that I'm having a certain strange feeling. Then she asked me to describe it as I've not slept for weeks, but today I'm feeling sleepy. Then they smiled. I said, okay, it looks like that's a good news because the pressure has been so high that I just cannot shut my brain. And now they had to also manage the baby as well. Fast forward, baby also got sepsis. It was a whole lot post surgery, and I was referred to a bigger facility to take care of the baby. So went into NICU ICU. Then I had to do the kangaroo mother care. The journey went on and on. And everything put together, I spent about 3 months out of my house because of preeclampsia, and then returned back home a week before Christmas to join my family. It hasn't been the same with me ever since that experience. And one thing I must say is preeclampsia is not loud. It's not, you're not going to get symptoms that will make you feel agitated, or it's very quiet. And before you know it, you are at the last stage and you are crashing. So a lesson I took from that experience, never take pregnancy for granted. Even if you have given birth to 10, each of them is very different. And every week, every day, every hour counts. Every symptoms that you feel, you have to take note of it. And awareness creation is very key. I learned about preeclampsia after my experience. So I'm very happy to join the cafe to share my knowledge and then educate other mothers, other midwives, other health workers that are there, because these are not normal things that you see every day at the hospital. Once it comes, it's an emergency and you have to deal with it. Yeah, thank you very much.
Exactly. Thank you so much, Joanna. What you said hits a lot of points and really sets the scene for today's webinar. Thank you for sharing that very profound and very difficult experience with us. I mean, for many of us, we may never experience preeclampsia. Maybe we've cared for women who have experienced preeclampsia, but sometimes we don't really put ourselves in their shoes for a minute to know what the experience really is like, the toll it takes on your family, the toll it takes on your work, the toll it takes on your body, and the lifelong sort of like implications of it. So thank you so much for sharing that experience with us. So that actually sets the scene for today's webinar, because we are coming to discuss preconception care. So even before a woman gets pregnant, can we do A, B, C, D? Is there anything that we can do to help this woman so that it can reduce her risk of getting preeclampsia? That is what today's webinar is all about. So thank you so much.
Thank you.
Just moving on, I'd like to introduce our two speakers for today. Gisela is a colleague midwife, just like me, and she's currently a midwifery tutor in Accra. She has over 17 years of experience in clinical practice and health education. She's a preconception care specialist, and she's really passionate about improving maternal and newborn outcomes through evidence-based teaching, mentorship, and community engagement. Gisela has led several preconception care workshops for women in Accra, and she's shared her expertise on GTV and other media platforms. In addition to her clinical and educational work, she's the CEO of Maryland Montessori, and we are so happy to have her share that sort of midwifery perspective with us. But we are also privileged to have Dr. Faisal, and he's an obstetrician gynecologist at Ryan Medical Center, as well as an entrepreneur and a consultant in organizational leadership and governance. He's the founder and CEO of Ryan Medical Center, which was recognized as a private health facility of the year at the Ghana Business League Awards in 2025. He also founded the Dr. Faisal Sule Foundation, and he's deeply passionate about reproductive health. He's married and a proud father of 5 children. Dr. Faisal, you have to share the tips with us. All right, so we'll have our first speaker, Gisela. And Gisela, I'll give you 20 minutes. And please go ahead and share your screen and take it away. Thank you.
Thank you very much, Isabella. All right. Thank you so much for the opportunity. And
Gisela, if you can put it in slide mode, because we are not seeing it clearly.
Is it?
Just put it
Is
in
it okay
slide
now?
mode. No, it's still yeah, it's perfect. Thank you.
All right. All right. Thank you very much, Isabella. And thank you very much, Madam Joanna, for your wonderful, the experience you shared through your journey with preeclampsia. It was really emotional. And I believe that we are going to really learn a lot of things after this presentation. So we are looking at preconception care and preeclampsia reduction. So this is my presentation outline. We just want to know what preconception care is and what it entails. We also look at a brief overview of preeclampsia, and then also we would like to also know whether preconception care has a possible being a possible game changer for women at risk of preeclampsia. And then we'll also look at the enablers and barriers to preconception care in Ghana. And then finally, we look at the steps that one can take, especially when it comes to preconception care. So basically, when we talk about preconception care, we are looking at a care any woman receives before she gets pregnant. So with preconception care, any woman in her reproductive age is the perfect candidate for preconception care. And it's not only about women, we can also have men going through the same care. Now, when you listen to our wonderful sister's story, you realize that when one gets to have a care or receives preconception care, it has a long way to help with saving lives. Because when we look at this, we are looking at early screening saves a lot of lives. Now, evidence has indicated that when women at risk of preeclampsia are identified, and these women are taken through care, they tend to reduce their chances of getting preeclampsia. And as such, it also helps to reduce the complications it has with the woman and then the baby. Now, WHO defines WHO defines preconception care as the provision of biomedical, behavioral, and social health interventions to women and couples before conception occurs. And its main aim is to ensure that the health of the woman it also aims to improve the health status and reduce behaviors as well as individual and environmental factors that can contribute to poor maternal and child health outcomes. So when you look at preconception care, its main goal is to ensure that every woman its main goal is to improve upon maternal and child health, both in the short and long term. Now, why is preconception care period very important? Now, I always say that, so when a woman gets to prepare herself before she gets pregnant, it means that she gets that utmost state of health, and we are looking at having very quality eggs. And when these quality eggs are fertilized, we believe that we are going to have a healthy fetus. Now, when it comes to preconception care, the early stages of fetal development as in organogenesis is very important. And when the woman has received that optimal state of health, these processes becomes very smooth, or transition becomes very easy. Now, when the woman's body is also well developed, it also helps to reduce her risks of getting complications. And this also goes a long way to help with the fetal development. So we always state that healthy beginnings don't begin at birth, they rather begin before conception. Now, why do you plan your pregnancy? When it comes to preconception care, I always say that it is the only opportunity by which a woman takes charge of her health, or if it's the couple, they take charge of their health, because it helps you to actually know yourself. It helps you to actually work on your habits or certain behaviors, so that at least you can also be able to get a healthy self. And then when it comes to preconception care, it's made up of a lot of packages. And these packages have a long way to help the woman or the couples involved. And when we go further, I'm going to discuss some of these packages so that we see how beneficial it is to the woman. Now, finally, the main aim is to reduce or promote the health of women and their newborns. So imagine a woman has obesity, which is one of the risk factors of preeclampsia. If this woman gets there, we believe that such a woman is likely to have children who are overweight, or these children can even develop cardiovascular or metabolic diseases later in life. So one thing about preconception care is that when the woman gets the care, it also helps reduce her chances of developing preeclampsia, and also the effect it has on both herself and the baby. Now, this is the components of preconception care. In fact, it's made up of a lot of packages. Now, during the care, one gets to have assessments with nutritional conditions, because actually nutrients, we also need healthy cells through good feeding or correct processes of feeding. So we have nutritional conditions being assessed. Now, during the care, we also have genetic conditions being assessed. Preconception care also gives the opportunity for a woman who has infertility or subfertility conditions to be treated. It also gets women who have gotten sexually transmitted infections or have HIV, and then certain environmental problems or factors that can impede or affect pregnancies are also worked on during the period. And also, preconception care, as part of the package, also look at interpersonal violence against women. It also looks at it as well. And then women or people who are on psychoactive substances, and then mental health issues also comes with the package. And then tobacco use, meaning that if a woman is able to go through all these packages, at least you are able to identify certain problems, and then they are treated before she gets pregnant. What have been our sweet success stories when it comes to preconception care? Now, when our sister shared her story, you could realize that there were a whole lot of things which came out through the journey. And WHO is expecting that every woman should have a positive pregnancy experience. And therefore, when preconception care comes in here, we realize that it helps to prevent spontaneous abortion, It also reduces intrauterine growth restriction. It can also reduce congenital malformations. And then also, if we have a client who already has an elevated blood pressure, it is normalized before she gets to get pregnant. And then it also assures effective contraception. Yes, because we have some women who we have to actually take time to ensure their BPs are stable. So we actually introduce them to some sort of natural or some contraceptive methods so that they can buy time with them before they decide to get pregnant after the treatment. And then also, when one of the sweet successes of preconception care is that there are better treatments for complications. So in case during the treatment, a woman is identified of having any complication, these complications are treated before she decides to go on to get pregnant. Now let's look at a little bit of overview on preeclampsia. Now we are saying that preeclampsia is a hypertensive disorder, and it's affecting approximately 2 to 8% of pregnant women, contributing to about 16% of maternal deaths globally. That is WHO 2019. And then also, when it comes to maternal death and fetal death, we have preeclampsia causing more than 50,000 maternal deaths and over 500,000 fetal deaths worldwide.
Okay.
When we come to sub-Saharan Africa, hypertensive disorders of pregnancy remain one of the major public health challenges, contributing to approximately 22.1% of maternal deaths. Now, looking at preeclampsia, it's also associated with multiple adverse maternal and fetal outcomes. Some may even persist through the puerperium, and this can give the woman or cause her to have increased risk of long-term cardiovascular conditions later in life. Now, when it comes to management and early diagnosis of preeclampsia, we believe that it helps to save at least 2 lives, that is that of the mother and the baby, meaning that when we are able to identify women who fall under the risks, they are taken through management or they are treated, or they go through the preconception care, we are assured that the lives of both the mother and the child is safe. Now let's come to Ghana. So in Ghana, preeclampsia is on an increase. It's still on the increase, especially when it comes to Greater Accra region, Central region, Ashanti region, and the Volta region. And we have preeclampsia still on the high side with these regions. And in Ghana alone, talking about case facility rates, we are talking about 3.9%. And then when we talk about preeclampsia as well, initially we always think hemorrhage is a primary cause of maternal mortality. Currently, it is preeclampsia, which is causing a lot of contributing to a lot of maternal mortality. And funny enough, we have a lot of women ranging 18 years suffering from this condition. Now, when we look at our postpartum readmissions among women with preeclampsia, we have about 46%, which is really on the high side. Now, what are the predisposing factors for preeclampsia? So we have primiparity. Now, when we have previous histories of preeclampsia, if a woman had had a previous history of preeclampsia, she's at risk of getting it. Women with multiple pregnancies, in vitro fertilization, women with chronic hypertension, they are at risk of getting it. Women with renal conditions or diseases, and then women within these age brackets, less than 18 years and over 35 years. Now, family histories of preeclampsia can also put a woman at risk of it. Women with diabetes mellitus and obesity can really be part of the predisposing factors to the condition. Now let's look at the journey for PCC. How is it like? Now, when our sister shared her story, she mentioned that she only got to know about preeclampsia after her episode. But imagine that she had known or gotten the information about it, it was really going to help with the process. Now, with pregnant or women, generally women, when they get the opportunity to go through the process, it helps them to understand the risks before pregnancy. So if you know you're at risk of getting preeclampsia, and based on the predisposing factors I mentioned, it makes you understand the risks ahead. And then it also gives you or provides guidance on how to reduce the risks before conception. Now, it also helps the client to get proper monitoring before she decides to get pregnant. Now, one other thing too is that it helps you to identify existing blood pressures, because we have a lot of people who actually check their blood pressures for the very first time before they get to know that they have a high blood pressure. Some people don't. In our part of the world, people actually don't actually have the time to go for medical exams every year just to check their health status. And as a result of that, you may chance on somebody who was just checked, and then before you realize the person is having a high blood pressure. And then also, the journey also allows time to investigate underlying causes of the hypertension. So if you are identified, we try to investigate what is actually causing the hypertension. And then it ensures that every woman gets the right treatment before they decide to get pregnant. So with whatever I have mentioned, you realize that when you have a high blood pressure at a very young age, or you have a very difficult to control hypertension, or your hypertension is such that it has no clear histories or whatever, it will give you this opportunity to understand the journey ahead. So what does preconception care for preeclampsia reduction entail? Now, when a woman gets, any woman who is identified to be at risk of the condition gets the opportunity to go through certain steps. And the first step is that as midwives, we have what we call the risk assessments. When it comes to risk assessments, in case we identify somebody who is at when we identify any woman or any woman comes for the care, we start with the risk assessments. Risk assessments entails one, history taking. So with the risk assessment, we try to take history. What type of history do we take? We take their personal history, their social history. We try to take their medical, surgical, past obstetric histories, menstrual histories, and the like. We try to take all these histories to be able to identify a specific risk. Now, apart from that, we do a physical assessment to actually check the client, do a head-to-toe examination to also further understand the cause of their risks. And then also, we also do check their vital signs, and then we also get the opportunity to run certain labs. Now, the next stage is to do proper health education, but we can do it better. Before we do the education, we need to check what we call the body mass index. We just want to see your weight against your height. And then we put you on a classification, like we try to classify you, whether you're underweight or you're overweight or you're obese. Because we believe obesity is one of the risk factors which causes preeclampsia. So you need to check and know your classification. Now, based on the risks we identify, it also gives us the ability to do proper health education. So if we have, during our risk assessments, any specific risks we identify, that is when we do proper education. And as part of the education, we do counsel on good nutrition, we do counsel on stress management, we do counsel on personal hygiene, environmental education is given to you, but specifically we target the risks we have identified. Then if we have to interpret results and what have you, then that also comes into play. But one beautiful thing about preconception care is that we work as a team, in that you have the obstetrician coming in, the physician, the psychologist, you have the pharmacist, the dietitian, and what have you, all coming together to support the individual. Then when we realize that everything is said and done, then you can be encouraged to get pregnant. So this duration can occur between 3 to 1 year for the preconception care. Now, risk assessment. I think I've said much about the risk assessment with the history taken. Now, imagine we have a client who is at risk or visits the facility to actually have herself checked before she gets pregnant. First and foremost, we need to interact with the person to evaluate for any high or any moderate risk. When I talk about high risk, we are talking about maybe the person having diabetes, kidney disease, just like the risk factors I mentioned initially. And then we can look at the moderate aspects where we are looking at the BMI greater than 30. We want to see whether the person is over 35 years and others, or the person has had a long-term pregnancy, in that the first pregnancy and then the maybe current pregnancy is taking a duration of 10 years. And this is what the criteria we can classify you as having something moderate. Then after the identification, do proper counseling. So the counseling actually helps to educate you about the condition, the signs and symptoms, the importance of early reporting to the hospital, and then the cares you will need before you get pregnant. And then generally with preconception care, I mentioned that we have to ensure that you are feeding well. We try to find out what you are eating, the kind of work you are doing, whether it can have an effect on your pregnancy, and the kind of activities you get yourself into. We also want to know your lifestyle. Do you drink? Do you smoke? And also, we also want to know whether you also take in so much caffeine. So all these things goes into the assessments. And then we also request for some labs. You know, one thing about preeclampsia is that it affects all the organs in the body, the major systems in the body. And as such, we need to also run tests to ensure that the kidneys are fine, the liver is fine, and what have you. Then also, you're also given the opportunity to be educated on how you can manage your condition. So if you are known, like as we have identified you of having the risk, you have to also know your blood pressure, and then whether you have to also get your own spin, or you can also maybe get to have regular checkups so that these your blood pressures are continuously monitored. Yes. And then when it comes to mental health status, there's not every woman who is so happy when they realize that there is a problem identified with them. So when we also realize that, yes, you will need some aspects of mental support, as in looking at coping mechanisms, techniques to reduce stress, techniques to cope with certain situations and whatnot. We can also refer it to the appropriate courses for proper intervention. Now, so let's see some of the strategies we put in place to reduce the risk. First and foremost, we need to ensure that the blood pressures are well managed. The blood pressures can only be well managed when the client is also made to have or gets the opportunity to also meet the physician, so that at least if we are planning to have a pregnancy, we ensure that if you are on any particular antihypertensives which will not support the pregnancy, either is changed, or the ones that you are taking, either the dosages are also reduced, or if you are on any medications which could also affect the pregnancy, it's also changed. Now, we also look at certain supplements or certain supplements which could also help to support the pregnancy. So generally, when it comes to preconception care, folic acid supplementation is one particular supplement we encourage a lot. Now, we also encourage a lot of dietary intake, in that we want you to take in a lot of fruits, vegetables, and then take in low sodium foods. And also you should be able to take in, well-balanced diet, so that at least you can have a healthy self to be able to support the pregnancy. And then also weight management. When women are able to control their weight before they get pregnant, it really helps with pregnancy outcomes. So we are looking at aiming at a BMI or body mass index between 18.5 to 24.9. And this, we believe that when this ideal weight is gained, when the pregnancy comes in, it also tends to reduce complications or conditions that leads to these conditions. So,
Gisela, sorry to cut you short. Can you please round up in the next 5 minutes?
Yeah.
Thank you.
Okay, all right. Okay. Let me quickly come to the current barriers to preconception care in Ghana. So in terms of preconception care in Ghana, you realize that, so I did a study on the experiences of midwives when it comes to preconception care delivery. And I realized that most midwives stated that they hardly get women coming to them for the care. You only see women coming when they have fertility issues, or maybe they are having one problem or the other before they will come. But for you to get a woman, sound completed, just married, coming to have preconception care once in a while, that is when you can. In fact, women who tend to come for the care are women who have gained some knowledge about preconception care, and then women who have also had a chance to visit our family planning units. They were the people who actually come for the care. So we are talking about just, we have a lot of women out there. I believe a lot of people never planned their pregnancies. They just realized they got married and then they just got pregnant and then they had to continue with it. Now, another thing was limited awareness, as our sister shared. We have a lot of, hypertensive cases, diabetic cases coming to the ANC all the time, but you hardly hear preconception care being mentioned. So we realize that a lot of women are not even aware of the care. And then also, even if they are aware of the care, where do they go to seek for care? When you visit our facilities, you can see the ANC unit, you can see the labor ward, you can see postnatal, but there's nothing like preconception care units. It's only some few facilities which are woman care units, but how many women know what goes on there? So this is one of the challenges being a barrier to preconception care in Ghana. Now, when it comes to even our health system, the midwife is willing to do it, but she already has a lot of cases at the ANC, and this particular care requires expertise care. You need to really get knowledge about the clients you are handling. It takes much of time. So you can't actually add this particular care to other cares, as in having ANC cases with clients coming in for preconception care. And then the logistics, the resources, you realize that it's also a challenge. And then when it comes to the tools, we don't have any special guidelines when it comes to preconception care management. And this makes this as some of the barriers which also affects the care. And then, so now let's look at it. How can we enable or improve preconception care in Ghana? I believe when we put this question across, when do you plan to become pregnant or do you plan to become pregnant in the next year? I believe this particular question can also ring a bell on the minds of people to get it involved. Now, we can also start it in our own way, in that even though we may not be able to completely start the care, but at least talking about it during the ANC and then around the family planning unit, at least people can get the idea and then come to also solicit for care. Now, we have to also promote male partners when it comes to preconception care. Yes, I believe when we involve the men, we are going to get a lot of the women. And then also CHIPS. We have a lot of CHIPS coming up. We believe that if it's infused in the CHIPS program, we'll get a lot of women to gain the knowledge and the confidence to even come for the care. So creation of awareness using webinars like this can also help with preconception care. Now, what can Ghanaians do before they get pregnant? You have to actually know your blood pressure. You have to check it regularly. You have to also visit a midwife or a doctor before you decide to get pregnant. And then you have to also ensure that if you have any pre-existing condition, you make sure that you regularly visit the hospital. And then also, if you are obese, you also work on the weight. Now, we have to also resort to healthy eating. We have to eat right. And then we have to also reduce our salt and processed foods. And then we have to start with supplements. Our folic acid supplements is also very, very important. We need to also get it. And then also alcohol intake, smoking, and then use of certain drugs must also be reduced, or we have to stop it at all, stop it entirely. And then every woman has to get in mind to plan the pregnancy. And we have to also make sure we choose a health facility early so that it can also help with preconception care. So generally, I wish to share about preconception care. Thank you very much.
Thank you so much, Gisela. The past 25 minutes have been really insightful. Thank you so much for your presentation. There's been a lot of buzzing in the chat, but we are running out of time, so we'll just go ahead with Dr. Faisal, and we'll take questions at the end. Dr. Faisal, over to you. Please share your screen. You're on mute. So whilst we wait for Dr. Faisal, please keep your questions and your comments and your suggestions coming in the chat. I see a couple of comments that, yeah, most pregnancies are unplanned, and so there isn't any preconception care. That's true. And also, we need to create more awareness. So keep your questions and comments coming in the chat. Thank you. Dr. Faisal, over to you.
Thank you very much. Please, is my screen showing?
Yes, it is. Everything is good.
I hope I'm also audible.
Yes, you are.
A very good evening to the audience, and thank you very much to the organizers for such a wonderful opportunity to share the little knowledge we have and make impact. Yeah, so I'm Dr. Faisal Sule, as rightly said. My task here isn't to do much. I'll be tasked to, first of all, mention the preconception risk factors for preeclampsia. That's the risk factors that we can identify before pregnancy. And secondly, to touch on early antenatal linkages, as well as go through the referral system. This is going to be the outline for my presentation. By way of introduction, hypertension complicates about 2 to 8% of pregnancies, according to the American College of Gynecologists. And worldwide, it accounts for about 14% of maternal death. And in Sub-Saharan Africa, it contributes to morbidity and mortality, and it's more so in Sub-Saharan Africa. Also in Sub-Saharan Africa, a study showed that the incidence increased from 2.2% in 2010 to 2.6% in 2018. Currently, the average overall incidence is 13%. In Ghana, preeclampsia, which is a complication of hypertension, is a leading cause of maternal mortality. That's the second only to postpartum hemorrhage. A study in Kolebu Teaching Hospital by one of our consultants just last year also adds to the fact that preeclampsia remains a leading cause of maternal mortality. By way of definition, preeclampsia encompasses two things. The first being the high blood pressure recorded, and then the second, protein found in the which we call proteinuria. With respect to the high blood pressure, a recording of high blood pressure of 140 greater or equal to 140/90, that's 140 systolic or 190 or 90 diastolic. On separate occasions over 4 hours apart, or a blood pressure recording of 160 millimeters of mercury for systolic or more, or 110 millimeters of mercury for diastolic or more, within a few minutes in the same facility passes for preeclampsia, and this normally occurs after 20 weeks of gestation. 20 weeks being because of the fact that the second wave of lymphoblastic evasion occurs around 18 to 20 weeks. By way of classification, preeclampsia can be classified into two forms. Okay, we have preeclampsia with severe features and preeclampsia without severe feature. And for purposes of the non-medical people on the call, preeclampsia basically means high blood pressure recorded during pregnancy. And in most cases, the patient doesn't need to have hypertension prior to the pregnancy. So when you have high blood pressure and protein also peaked in your urine, then the diagnosis of preeclampsia is made. It's said to be with severe features when we have features such as symptoms or which can take the form of blurring of vision or severe frontal headaches or nausea, vomiting, and some also physical, in some cases, physical examination findings can also be features of severe findings. Others are laboratory findings, which are mainly full blood count showing low levels of your HB and also low levels of the platelets. The indices in the kidney may also show, liver will show increased transaminases, which may be twice the upper limit of normal. The kidney function test will also show an increased level of the creatinine. There are certain imaging findings that may also suggest preeclampsia with severe features. They include CT scan of the brain showing cerebral edema, and also in some cases where you may have the bilateral parieto-occipital swellings in the brain. A chest X-ray may also show pulmonary edema. An abdominal scan may also show a problem with the liver as well. And when pelvic scan or obstetric scan is done, you may find the baby looking small for the gestational age. And ultrasound, Doppler findings may also show either decreased or absent end diastolic flow, which are all consistent with severe findings in preeclampsia. Some complications of preeclampsia include what we call the HELP syndrome. This mainly when we have hemolysis or breaking out of blood cells, the red cells, in the setting of elevated liver enzymes and also very low platelets. This may lead to bleeding from orifices, including gums and all that. There is also a complication we call placenta abruption, where the placenta can suddenly detach or misattachment, which may lead to a severe complication, which requires immediate delivery to save the life of the baby. That's if the baby is alive. Preeclampsia may also lead to preterm delivery. It will also cause fetal growth restriction because it's mainly a disease of the placenta. Preeclampsia can also affect the mother by leading to maternal organ damages. This organ damage may be an acute kidney failure or an acute heart problem and may even lead to stroke in some cases. I'd like to move on and touch on the risk factor for preeclampsia, which I'm going to divide into pre-existing medical conditions and then personal and family history, and the third being physical and lifestyle factors. With pre-existing medical condition, it's been found out that people with chronic hypertension stand a higher risk of developing hypertension during pregnancy, as well as preeclampsia during pregnancy. Diabetes mellitus, whether diabetes, that's whether it's type 1 or 2, has been found to also affect the placenta, leading to an increased risk of preeclampsia in people with type 1 or type 2 diabetes. With patients with kidney disease prior to conception, it's been found out that they normally struggle to cope with the increase in blood volume during pregnancy because the body is already having a high level of fluids due to the kidney failure. There's already retention of fluid in the body. With obesity, it's been found out that especially those with a BMI greater than 30 have issues and often develop preeclampsia during pregnancy. Autoimmune diseases such as the SLE and antiphospholipid syndrome has been found to affect the placenta and lead to poor development of the placenta. This has also been found in histopathology findings, which shows high levels of ischemia in the placenta, as well as microthrombia found in placenta of people who suffered preeclampsia during pregnancy. The same applies to connective tissue disorders, which also affect the placenta to a very large extent. And to those on the call who are non-medics, preeclampsia is basic, or hypertension in pregnancy is basic, a problem with the placenta, and it's to a very micro level got to do with the endothelium. So whatever there is preeclampsia or hypertension, we assume there's a problem with the placenta, and the placenta is the interface with the mother, and then that's the unborn baby. So any problem affecting the placenta may lead to the baby suffering as such. So in most cases of severe hypertension or preeclampsia with severe feature, we expect that once the complication sets in, and we have delivery, which leads to the delivery of the placenta as well, we assume that the problem may come to an end. But in some cases, the problem may continue for other reasons. Back to the risk factors for preconception, that's risk factors that can be identified before conception. With regard to preeclampsia, a previous history of preeclampsia increases your chance of getting preeclampsia in the index pregnancy or in the pregnancy yet to come. It's been found that most of people who suffer severe forms of preeclampsia, or people who suffer the preeclampsia earlier means before a gestational age of 34 weeks, are at a higher risk of developing preeclampsia in subsequent pregnancy. Also, a history of small for gestation age or adverse gestational outcome, that's adverse pregnancy outcome, has been associated with an increased risk of preeclampsia in subsequent pregnancy. With regard to family history, it's been found that those women whose mothers or immediate sisters, biological sisters, suffered, that's the first degree relatives, suffered preeclampsia in a previous pregnancy, has a higher risk of developing preeclampsia compared to the average population. With respect to maternal age, we realized both extremes of ages affect your chance of getting preeclampsia negatively. The reason being, with respect to lower ages such as 20 years or less than 20 years, some literatures also quote less than 25 years, it's been found that such people normally have a high risk of developing preeclampsia. And also higher ages, that's more than 35 years. And it's more also found that the older the age, the more dominant or the higher the risk, with people over 45 years of age even having higher complications, more severe complications such as acute kidney injury from preeclampsia and also acute heart failure as well. A previous miscarriage with the same partner also is a risk factor for preeclampsia in subsequent pregnancies. Also, other conditions such as the hereditary, sorry, the word is hereditary, that's a typing mistake. Hereditary thrombophilia also leads to an increased risk of preeclampsia. When it got to physical and lifestyle factors, it been observed that people with obesity, that's BMI of over 30, are more likely, as I said earlier. Also, people with first-time pregnancy, that's has been found to have a higher risk of having preeclampsia compared to those who have had earlier pregnancy, and this even so with the same partner. Long pregnancy interval also been found to be a risk factor for preeclampsia. It's been found that once the interval between subsequent pregnancy goes beyond 10 years, the body's probably risk for developing preeclampsia is similar to that of somebody who's having pregnancy for the first time. With IVF, that's one form of assisted reproductive technology, it's been found that there's a higher risk of preeclampsia. This is mainly because studies have found out that IVF is mainly associated with increased risks of hypertensive disorders, and for that matter, the increased risks of preeclampsia as well. And this more so with multiple gestation, that's twins, triplets, and quadruplets, and so on, pregnancy. People who also abuse drugs have been found to have a high risk of developing preeclampsia in subsequent pregnancy. So the purpose of this is for us to be able to know what we can do what we can do best to prevent preeclampsia, especially in cases like those with physical and lifestyle obesity, which are modifiable risk factors such as obesity and then also the pregnancy interval. We should be able to do something about that. Even IVF can be avoided. Also on assisted reproductive technology, though IVF has been found to have higher risks of preeclampsia, also the other forms of assisted reproductive technology, such as the ICSI, has not been found to have any risks associated with or does not affect the risk of getting preeclampsia. The other leg of my presentation got to do with the referral pathways and then early antenatal linkage. Early antenatal linkage and effective referral pathways are essential components of maternal health, and these two have been found to play critical role in reducing the incidence of risks involved in preeclampsia, as well as reducing morbidity and mortality. Ideally, early antenatal linkage got to do with probably encouraging pregnant women to start their antenatal in the first trimester. You should be able to start before the end of the first 12 weeks. That's in the first trimester. Most often, we see pregnant women waiting till they get to 3 months before reporting for antenatal, which isn't a good practice. The practice which should be encouraged is for them to start antenatal visits before the pregnancy achieves 3 months. Sorry, before the pregnancy achieves the 3 months, that's the 12 weeks, and not after the 3 months. The objectives of early antenatal linkage includes it helps the clinician and then the pregnant woman identify high-risk pregnancy. And this identification, this normally comes through taking a very extensive history. You ask the woman the age, and then also previous history, family history of preeclampsia. Through taking a very good history, able to probably identify those who are likely to have a high risk of getting preeclampsia. Also, after history, we do the examination. During examination, you should be able to pick those with a high BMI and other clinical findings or examination findings that would suggest a high risk of getting preeclampsia as well. So after the identification, we're able to probably plan for such pregnancy and then categorize them accordingly and give them special attention. The other objective is for us to be able to know the baseline laboratory investigations. For instance, you'll be able to tell the baseline kidney function. If there's already a kidney problem, you'll be informed. But the Ghana Health Service current protocol does not encourage kidney function, liver function, other ones. But basically, we do the full blood count, the cycling, the full blood count, plus others as baseline investigations. And once we're able to identify a patient or a female as having a high risk of developing preeclampsia, more so in the first trimester, that's less than 12 weeks, and we're able to then start low dose aspirin, 75 milligrams or 150 milligrams, and also calcium. These have been found to drastically reduce or significantly reduce the risk of getting preeclampsia and eclampsia during pregnancy. So this is something we often do to people with chronic hypertension and other conditions that probably are likely to generate into or increase the risk of getting preeclampsia and affect the woman. Also, once you're able to catch them early, that's before the 12th week of pregnancy, you're able to educate them well and then get them better prepared for the pregnancy. The importance of early antenatal linkage got to do with early detection of hypertension, that's during the early visits, and also allows time for the needed intervention, as well as prevention of complications such as eclampsia, such as the HELLP syndrome, such as the acute kidney injury, the heart problems, or even the strokes, which is not so common. The early antenatal leakage, what happens during antenatal leakage got to do with, basically, you check your blood pressure. So once you check your blood pressure, we're able to tell whether you are likely to be somebody with chronic hypertension, which is a risk factor, or probably having normal blood pressure. Even when the blood pressure is normal, with time, at subsequent visits, we're able to compare the the booking blood pressure, that's the very first one, with the subsequent one. So an increase we're able to based on the increase or to tell whether you're hypertensive. It doesn't always have to go beyond the 140/90 before we diagnose hypertensive. There are certain levels of increase in systolic of more than 30, diastolic to a level that you can even diagnose blood hypertension in pregnancy. And for that matter, if there's protein in the urine as well, we can confidently make a diagnosis of hypertension or preeclampsia, even though the blood pressure may be less than 140/90 in some cases. Also, we're able to do urine or urinalysis. So we're able to tell whether you have protein in urine or not. And I stated earlier on to be able to take a very comprehensive or detailed medical history as well as examination, and we're able to, based on that, assess for risk during the early antenatal linkage. So provided you're not able to come to the hospital early before the end of the first 12 weeks, you all miss these opportunities and the risks may be associated with you undetected, which may lead to a very high risk of getting preeclampsia and causing damage. With respect to referral pathways, they are basically got to do with a way of identifying, once you're able to identify someone with a high risk, also you know how or when to transfer from a lower level healthcare facility to a higher level healthcare facilities. And normally we have mainly three: the primary, the secondary, or tertiary. And this also this globally, and also that's the same thing that the Ghana Health Service also employs. At the level of the primary facility, we have facilities such as the church compound and health centers, some private hospitals also fall under these categories. And what they basically do is, and normally, in most cases, is a midwife-led clinic that provides basic antenatal care and screening for pregnant women who report early. And the purpose or the aim is to identify high-risk pregnancy. Normal pregnancy, they are likely to continue managing till a certain gestation that they may refer or probably may even deliver at such facilities, depending on whether they have the capacity or not. But the main purpose is to identify the high-risk cases based on the history and then the examination and the investigations that they do, all of which will be referred. So the second got to do with the secondary level hospital, which are mainly district hospitals here in Ghana. And what they do is they normally manage moderate complications, having received referrals from the primary level facilities. And before they also refer, or at their level of management, they make sure they initiate treatments such as the use of antihypertensives to bring down the blood pressure, and also the administration of magnesium sulfate to either prevent the fits or for neurodevelopment. So the tertiary levels normally got to do with the regional hospitals and then the teaching hospitals. Yeah. So what happens here are normally where we have a lot of specialists and provide specialist care. So you may even have a whole renal unit providing renal treatment for people who may come with AKI. We may have multi-specialty units with also do management of severe cases with severe complications as well. They may have the capacity such as intensive care units, so they can offer intensive care services and also both to the mother and then to neonatal intensive care support and other forms of support. Having said that, the practice is such a way that we're not able to go strictly by what we have, but we always so it may have somebody doing more than is required of him or her, a practitioner at the primary level, because of some of the challenges we have in the system. But that said, we always encourage that you refer appropriately based on the level or severity involved. The reason being, you may have the skills, but given the facility you find yourself, you may not have the tools or the support to do what you are able to do. So we are advised to follow this. And this also follows what Ghana Health Service or the Ghana protocol also states. The indications for referral during such early clinics are normally the high blood pressure, which may be 160 over 110 millimeters of mercury or more, and also the presence of features which show severity. This may be persistent headache, visual disturbance, some right apogastric pain or epigastric pain, and even convulsion in some cases. And also, when the woman complains of reduced fetal movement, then you may know that this may also be an indication for referral, and that the patient will require further investigation and monitoring. The referral process, we don't just refer, okay, but to make things in the best interest of the patient, to make sure the patient receive the needed care, it's best that, or the practice is just that whoever is referring is supposed to stabilize the patient before referring. And you don't really stabilize the patient, but you also make sure you communicate to the receiving facility. So provided you are referring to RAGE, Kolebu, or any of the tertiary facilities, or even from a primary to a secondary facility, you're supposed to have called their call center, inform them of the case, they know what they're expecting, they make preparations, even if they have to discuss with you, the one management, and probably make certain inputs before the patient comes, is in the right direction. So the communication is ineffective, and the communication doesn't end with just making calls, but also making sure you document your history, your examination, and also your examination findings as well as the investigation findings and the interventions you made so far, okay, in the form of a referral document, and then also which is supposed to have accompanied the patient. Transport of the patient is very essential. Normally, we advise you get a patient transferred by an ambulance in all cases of severe preeclampsia or even preeclampsia, even when severe patients, because stable patients, so to say, because condition can change at any time, and accompanied by paramedics, as well as somebody who has at least a basic knowledge of what it is in the person of a midwife, or even if you can get a doctor to accompany such a patient, is advised. Though often we don't have enough staff, so we're not able to do that. But that's the ideal thing to do. At least you shouldn't do in the taxi or in the private car. You should be in an ambulance. And then the last thing, which is very important, that we normally fail to do, is to follow up at the referral. Often, once we send the patient, we get space in the tertiary facility, we forget that patient, we don't follow up. But following up is very important. Checking on the patient is very important. It helps us get to know what happened, other interventions that were made. We get to learn from the experience, we get to document, and it goes a long way to make our practice better. It helps ourselves with the knowledge and experience as well. And this is a chart that basically shows what I have enumerated earlier, talking about the early antenatal linkage that should be less than 12 weeks of gestation. And the first visit, what we do, that's a blood pressure check, checking for urine protein. If it's high with the presence of urine protein, you know you are dealing with a preeclampsia case. And then you take a good medical and obstetric history as well. The purpose is to identify risk factors, and if there are risk factors, you start your prophylactic aspirin and calcium. Yeah. And then with a routine antenatal, normally we monitor the blood pressure and do urine check, and then fetal growth monitoring. That's what through the scans and also health education. When there are danger signs such as high blood pressure or protein or severe signs of any severity, as evidenced by headache or visual disturbance or any reduced fetal movement, we refer urgently. Yeah, before we refer, we make sure the patient is stabilized, the receiving facility that have been communicated with, we've done proper documentation, also is supposed to have transported appropriately an ambulance, like I said. Often we have a lot of challenges when it comes to trying to. We often have challenges when it comes to exercising what we do. The reason being, often we get our pregnant women coming after 12 weeks. Okay, some come as even after 20 weeks, where you're supposed to have had most of the cases happening or manifesting, and that's the problem. Some may come when they are in labor. Unfortunately, that's what happens in our environment, not even in the intervals, but even in Accra here, in the teaching hospital, you even have people just reporting when they are in labor and they just push the teaching hospital referred. And also the poor transport system also affects healthcare delivery as very much. So we are not able to practice what we preach as the early antenatal linkage. Our socioeconomic picture isn't so good, so people often have financial constraints, and the communication systems in some cases is non-existent. You are fortunate when you have a doctor calling a colleague doctor. There are times when the call centers are not just not working, or probably the lines have been off for a very long time, even with NICU. So those things happen, and those are some of the challenging. And in some cases too, often when it comes to healthcare provision, or probably even a doctor or midwife, you're able to only recognize or see what you know. Other than that, you may be seeing the signs, but you may not be able to decipher whether you're dealing with a severe condition of preeclampsia. So somebody may stay with the condition but not able to pick. So this may lead to delayed recognition. In some cases, too, due to the fact that the patient may not be so enlightened or educated on preeclampsia, those signs will be there, but he or she may not see anything serious. In the case of a survivor, we could tell she picked one or two signs and reported at the hospital even earlier. So that helped. Yeah, but if she was probably didn't know, just that she didn't know, she had never heard of the preeclampsia, she could have just waited. But she got a little alarmed and also go. So the delayed in recognition of the complications may also be a problem. One of the challenges of the early referral linkages that we have. In conclusion, I would like to say, from what we've learned so far, the early antenatal linkage can help with early detection of complications, and associated with a good referral system and effective referral together, we're able to prevent a lot of poor neonatal outcomes, and also prevent maternal morbidity and mortality. The woman's life is precious, and no woman should be allowed to die, or should die in an attempt to give forth another life. We all have to play a part. Okay, what the organization is doing is one thing very good. That's the action for preeclampsia. It's enlightening us all as the ordinary citizen, or probably patient, would be patient or potential patient. So we're able to pick up those things, and also reminding we the healthcare practitioners what to do, and also advocating. The government also has a role to play, I think, with strong political will. Some challenges such as those with transportation, with ambulance, and also the streets, the poor road network issues, and also enforcement of the protocols with strong political will be able to probably get there. And all of us are part of it. Nobody is left out. The last thing I would want to touch on is the fact that Ghana, Ghana, we also have our own our protocols, okay, which also includes the Ghana Health Service protocol that got to do with early antenatal. So that states that all pregnant women are also encouraged to start antenatal early, just as what I said, within the first 12 weeks. And there should be a mandatory booking visit, where there should be history taking, examination, and also urine protein. It's one of the basic labs in addition to the check for HB and then other things, and then also there should be a booking scan as well, and estimation of risks. That said, we also have in Ghana here the National Safe Motherhood Protocol, which we abide by, as well as the National Antenatal Care Guidance and the National Referral Policy, which is similar to what I enumerated, from the primary to the secondary to tertiary or paternity facility. I would like to hand over here. I thank you for the opportunity to
Thank you so
take
much.
part in this.
Thank you so much, Doc. It's been really enlightening. I think everything makes sense now. So just to recap what the two speakers have been talking to us in the last 1 hour. So we had Gisela, who first came, and she spoke to us about what do you do before you get pregnant? So it's sort of like, is there something you can even do when you are not pregnant or you're thinking about getting pregnant? So that encompasses more around preconception care. But we do know that in our setting, women do not plan pregnancy. Like, I have had 3 babies. I don't remember planning any single one. It's just a natural thing that occurs. And so it's not a very common thing in our setting. And so, Doc, thank you for letting us also know that if we don't capture these women before they get pregnant, there's that window of opportunity very early on in the pregnancy, in the first 12 weeks, where we can still get the woman, where we can still do a risk profiling or screening, and then we can give them all of these interventions. So your presentations have been spot on and really interesting. The chat has been buzzing. Whilst you were talking, I was busily typing away. So there are a couple of comments and questions. We'll just take one or two of them because we are out of time. But I think one of the things that people were asking was, let's say, in the rural areas. Okay, Gesela, this question is for you. In the rural areas, for example, how can we sort of like make sure that women are getting some sort of preconception care? Like, what can we do? Because we know that in the cities, there are options, isn't it? So maybe if the woman goes to Kolibu and she can't get that service there, she can access a private facility, for example. But women in rural areas, what are their options? What can they do? What can we do to support them?
Okay. All right, thank you very much. So everything boils down to education. And as I rightly said, when you go to the rural areas, we have a lot of the CHIPS compounds. And we also have a lot of community health workers, community health nurses, who are also really into the community. I believe when at least visiting the various homes and then we having women come into the CHIPS compound, we can have a lot of dedication there. Basically, we can also have them in posters pasted around for people to know what is actually happening in the facility. And I believe after delivery, during the postnatal sessions, midwives can talk about it to their clients that the next time you get pregnant, you should be able to visit us to make sure you are well checked before you decide to conceive. Yes, so I believe in the rural area, these are some of the things. And then one thing to our preconception care is that from my study, you realize that people believe that, in fact, the midwife needs to understand the culture of the community. That is the best way is going to really help with the care, because when people have their specific ways of doing things, like when people are pregnant in Ghana, they don't want anybody to know they are pregnant. But when you tell them the importance of whatever we are doing, they can willingly come for the preconception care services. Yes, thank you.
Thank you so much. Those were my thoughts too. So I was typing away in the chat that I really think that it's about community engagement and using the resources we already have. So just as you said, using these community health nurses who are at the very periphery, who can visit the women in their homes, can go to their churches, can go to the marketplaces, and just tell them, like, if you're thinking of getting pregnant, it would be really nice if you can pass by the CHIPS compound and like have a talk with us or something. So that's a really good point. Dr. Sule, someone was asking a really interesting question in the chat. So the question goes like this. If because of resource constraints, you have to choose between aspirin and calcium for preeclampsia prevention, which one will you go for and why?
Well, if due to resource constraints, I guess the person is thinking about money, okay? Because if it's due to availability or unavailability on any of them, you probably might have gone with whichever is available. Okay, so I want to presume probably due to not having money. So then you would probably have to do with aspirin. Okay, aspirin being cheaper, and then also in most cases it even started earlier in the pregnancy. So aspirin will do, but if you can also get the calcium, it's good to go. Often calciums they come in branded forms, which are very expensive, but aspirin is cheaper. So if the resource constraint is got to do with money, then you can do with aspirin.
All right. Thank you so much. I'm trying to share my screen. Do you see my screen at all, or it's your presentation, Dr. Faisal? Are you seeing my screen? I'm trying to share screen. Sorry, you're on mute. I can't hear anybody.
It's like I can see your screen.
All right. So you see questions and discussion. Is that what I have up on the screen?
No, Isabella, we can see Dr.
I'm still seeing my presentation.
Okay. Yeah, I don't know what is happening with my tech today. Well, I think we've run out of time, and so we'll not be able to take any further questions, but let's keep the conversation going on our social media pages. You can reach us on Facebook. We are on Twitter. We are on Instagram, WhatsApp, and also subscribe to our newsletters. We were putting in the chat box some of these links that you can join our WhatsApp community, or you can reach us on any of our social media handles. Sorry, I can't share my screen. I'm having some tech challenges now. So we'd also like to hear from you. So in the chat, we'll put in the link to our feedback. You can send us your feedback on this Knowledge Cafe and how we can make it better. And programs like this run or operate because you are supporting us, but we'd also like you to go a step further. If you'd like to reach out to collaborate, to partner with us, or to even sponsor the APEC Knowledge Cafe, please don't hesitate to reach out to us. You can yet again contact us on social media, and we'll be more than happy to. Before we round off, I'd like to say a big thank you to the planning committee for the Knowledge Cafe series. The director of APEC, Koiwa Koilabi, Dr. Dorothea Obri, Dr. Joyce Brown, Letitia Amane Opari, and Emmanuel Asari Ejay. Thank you so much for all the work that goes on behind the scenes to make this a reality. And we also want to acknowledge our partner, the Sports Steady Ghana. All right, so as a usual thing that we would do, we like to take a selfie at the end of the series, just so that we can have something to remember. So if you want to be a part, just turn your camera on, and then I'll say 3, 2, 1, and then we'll take a selfie, and then we'll wrap it up. So thank you so much to everybody who joined us. We've run out of time, so we couldn't take a lot of your questions, but keep them coming, and we'll try to address it in the next one. Or better still, we will continue the conversation offline. Alrighty, so are we ready to take the selfie? Joyce, can you help take the selfie? I don't know, something is happening to my computer.
Unfortunately, not because I'm on my phone right now. So someone who is.
I can help, Isa.
Thank you.
Please help, please rescue me. Okay, who is doing it? Is it Koiwa?
Yes, Isa, I'm taking it
All
up.
right.
Shots already. One more, please.
Okay.
Okay.
Well, thank you to everybody who turned their camera on. I see Joanna, Bless, Sebastian, Emmanuel, Gisela, anybody who turned their camera on, thank you. And thank you to everybody for joining, all 75 participants. And we look forward to seeing you in the next one. Bye.